Hello, everybody, and welcome to the debate. My name is Annette Sohn. I am with AMFAR's Treat Asia program here in Thailand, but we work across the region, and it's very nice to see many people who have been to the Bangkok Symposium in the past returning to participate. As Dr. Nguyen mentioned this morning, the debate is often a highlight of the program, in part because the debate allows a lot more discussion from the audience. We expect to have about 20 minutes of time where we will be asking all of you to come up to the microphones to ask your questions or share your comments about the proposition in the slide, which is statins should be standard of care for people living with HIV in the Asia-Pacific region. And you will be able to share your opinion about that at the vote before the debate, and also to share your opinion after the debate with a second vote. So if you're just entering now, welcome to the debate. And if you would like to participate in the electronic voting, please use your mobile phone to capture the QR code under workshop number 1 in your conference pass, and then you should be directed to a voting site or a website where you can provide a vote. So we'll go ahead and continue with the introductions for today's debate session. So the issue being debated is whether the use of statins to reduce cholesterol levels should be recommended as the standard of care for people living with HIV in the Asia-Pacific region. And we have 2 debaters in favor and 2 debaters against. You will see that there are only 3 people to my right. Dr. Chen-Song Wang is with us on Zoom and will join us shortly. He's already online. But I'll briefly introduce our debaters as we're getting settled for the debate. So Dr. Christine Erlandson is a professor in the Department of Medicine, Division of Infectious Disease at the University of Colorado, Denver Anschutz Medical Campus. And you heard from her in her plenary this morning, and her research is focused on the complications of aging, understanding the mechanisms of successful aging, and implementing interventions to ensure that among people living with HIV. But she's also one of our experts in the HIV community on cardiovascular complications of HIV. Dr. Kumarasamy gave a plenary yesterday, and he is the chief and director of the Infectious Disease Medical Center at the Voluntary Health Services Hospital in Chennai, India, which provides medical care for people with HIV, viral hepatitis, tuberculosis, COVID, and other infectious diseases. He also is the director of the Chennai Antiviral Research Treatment Clinical Research Center or site, which conducts therapeutics and biomedical prevention clinical trials in HIV and other infectious diseases. Dr. Wang Chen-Song was very sorry that he could not be with us in person, but he has really endeavored to manage some last-minute Zoom arrangements and will be live with us giving his talk. He is a senior consultant physician in the Department of Infectious Diseases at Tan Tock Seng Hospital and the National Center for Infectious Diseases in Singapore. He's the director of the National HIV Program and the head of the HIV, Viral Hepatitis, and STI Division in the Interim Communicable Diseases Agency of the Ministry of Health there. He's actively involved in HIV clinical care and interested in the socio-behavioral determinants of HIV, STIs, and their prevention. And our only cardiologist in the group, Dr. Prin Vatisartokit, is a consultant cardiologist in the Department of Medicine at Ramatipiti Hospital, Mahidol University here in Bangkok. He's the secretary of the Research Committee of the Royal College of Physicians of Thailand, and his research interests include cardiovascular morbidity and mortality and associated risk factors and prevention interventions. So this is the structure of the debate. In a few moments, I will be asking you to vote, and then we will have 6-minute statements in favor first, followed by against. So that means Dr. Christine, then Dr. Chen-Song, then Dr. Kumar, and finally Dr. Prin. And then we hope to have maybe 20 minutes or so, maybe 25, for questions from you all. So I really want to encourage you to write down your questions during their presentations and come right up to the microphones in the center of the room so that we can have a more integrated debate and engage with all of you here. And then we will have 2-minute closing statements with no slides, and we'll go in opposite order of against first, followed by in favor. So then Dr. Chensong, Dr. Christine, Dr. Prin, and Dr. Kumar, and we will ask you to vote again. So if you're just coming into the room, if you want to participate in the electronic voting, please go to the back side of your name badge and look at the QR code for workshop 1, top left, and then you will be taken to a link where you will see 5 voting options, although we will not have that many. And so we usually have an opportunity to do a test vote. And before we do that, a reminder that the winner is the team that changes the most minds. Now, this is not a popularity contest. This is a question of whether or not you change your position based on the presentations. It does mean it's a little more complicated for me to do the math up here on stage immediately, but hopefully you all will also help me to make a determination if we are close or not. So we will now have a test vote. So some of you here in Thailand know very well about the characters on this slide, Mudeng and Butter Bear. Some of you have never heard of these characters before, but that's part of the question. The question in the test vote for you is whether or not is Mudeng a more effective viral mascot for Thailand than Butter Bear? So we're going to ask you to vote. Yes, Mudeng is better. Or 2, no, Mudeng is not better. And 3, I have not heard of either. So if you have not heard of either, it might be because this is not your social media stream that you follow. And so again, go to the back of your conference name tag, workshop 1, QR code, and you should see 5 different options there. And we're going to let you vote. You get 15 seconds, 5 seconds to vote. Please select 1, 2, or 3. Okay, are we ready with our QR codes? Okay, we're gonna go ahead and vote. 15 seconds to choose Mudeng is number 1 or A, Butter Bear is number 2 or B, and 3 or C is I have not heard of either. So let's see what happens. Ooh, we have a lot of Mudeng supporters in the room. Give yourselves an applause. Good job, everybody. Okay, and as you can see, this we're going to basically do the same thing, but the next vote, you will not see the result. You will only see the result of your first vote at the very end. So let's go to the first vote. Yes, statins should be standard of care for people living with HIV in the Asia Pacific. If that's what you believe right now, you will be prompted to choose A or 1. Or 2, statins should not be standard of care for people living with HIV in the Asia Pacific. If that is your position, you would choose B or number 2, and we will now give you 15 seconds on the clock to vote. Ooh, ding, 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 ding. Okay. And so now we're going to go ahead and invite Dr. Christine to give our first presentation, and we'll ask the team to bring up her slides. Thank you very much.
All right, so I'm starting to convince you all that statins should be prescribed to all people living with HIV, especially those in the Asia Pacific region. To start, I'm going to give you 6 reasons. The first reason is that we know that pitavastatin decreases major adverse cardiovascular events and death in people with HIV, as shown in the REPRIEVE study. The first figure here on the left shows a 36% reduction in major adverse cardiovascular events in the setting of pitavastatin compared to placebo. And overall, we also see a 23% reduction in first MACE, or major adverse cardiovascular event or death, over the follow-up period, which makes it an easy answer of why we should give statins to everyone. Number 2, these results are apparent even in the global REPRIEVE population. Importantly, the REPRIEVE represented over 1,000 individuals that were enrolled in Southeast and East Asia and South Asia. So these results are applicable to the Asia Pacific population. And importantly, the pitavastatin effects were actually greater among participants in Asia and across, or Asian participants and across Asian sites. Overall, at the top, you can see that orange bar represents the overall hazard ratio with a 0.64 hazard or reduction in cardiovascular events with pitavastatin compared to placebo. That rate was even lower with a 0.22 hazard in the pitavastatin group in Asian participants, as shown by that first red arrow, and then down by the global burden of disease area. In the second red arrow, you can see that that rate was even lower in Southeast and East Asia, and in South Asia, it's off the chart because that is such a rapid risk, or such a major risk reduction. So again, more reasons that we should give this statins in this population. The third reason is that we see that pitavastatin is safe over 6 years of follow-up. Serious adverse events were similar between the pitavastatin and placebo arms in REPRIEVE. The more common symptoms of muscle myalgias were fairly uncommon, and mild symptoms were only slightly higher in the pitavastatin group, 1.2% versus 0.6% in the placebo group withdrew for muscle-related symptoms, and we saw no pitavastatin effect on rhabdomyolysis. Although diabetes rates were slightly higher in the pitavastatin group, this was really driven by metabolic risk factors and typical risk factors that we would expect to see. And furthermore, we see a protective effect of statins on MACE in those that did develop diabetes while on study. 1% of people in the pitavastatin versus 3% in the placebo group who had diabetes developed MACE. So it was even protective in those that did develop diabetes. And lastly, we saw no adverse cognitive effects in a sub-study of participants in REPRIEVE that were also enrolled in the HALO study. We'll be presenting more on that at CROI. As I mentioned in the earlier talk, we were particularly interested in the impact on muscle. We saw no effect of pitavastatin on objective physical function measures over 6 years. And then we also looked at measures of muscle density and muscle area in the mechanistic sub-study of REPRIEVE, and we saw no pitavastatin effect on muscle density or muscle area. And even more so, we saw a potential protective effect of pitavastatin on muscle area in the older population, suggesting that with ongoing use and over time, there may be a protective effect in preserving some important measures of muscle function and mass. The number 4 reason is that statins are recommended by treatment guidelines across the globe. You can see some of those treatment guidelines that now reflect statin use up in the upper right-hand corner. Per the Department of Health and Human Services guidelines in the US, the recommendations have been changed to reflect an A1 recommendation, or the strongest level of recommendation for pitavastatin in anyone with a cardiovascular risk of 5 to 20%, which is big for people with HIV. The guidelines were much more vague before, only recommended for 7.5 potentially percent or greater. They also went as far to recommend statin for anyone aged 40 to 75 with HIV who have a risk of less than 5% if they have other risk enhancers. And note those risk enhancers are in the box on the right, and that includes things like ethnicity of South Asian ancestry, as well as high sensitivity CRP that's elevated, and metabolic syndrome, common conditions that we see oftentimes in people with HIV. Although the data were insufficient to make a strong recommendation for people less than 40, I think there's growing interest in this population, and there may be ongoing benefit even for that younger age group. Number 5, statins have many additional benefits, including anti-inflammatory effects, immune modulatory effects, reduced oxidative stress, and other benefits. In REPRIEVE, we saw improved and stable plaque, improved cardiovascular disease biomarkers, and a trend even towards decreased COVID severity in participants prior to the vaccine. We see additional benefits of statins. There may be a decrease in some cancers with statins that's been shown in other populations of people with HIV, particularly with microbial-related cancers. Statins may also enhance outcomes in cancer treatments. Some studies suggest a decreased risk of tuberculosis and improved outcomes during treatment for tuberculosis. And in liver disease, there may be improved outcomes and slower progression of liver disease and hepatitis B and MASLD, all conditions that may occur more commonly in areas of Southeast or in the Asia Pacific region. So in summary, statins decrease major adverse cardiovascular events and death in people with HIV, and to a greater extent among people with HIV in Asia. Pitavastatin is safe even on muscle, and the diabetes rate was only slightly elevated with the protective effect of statins in that group. Statins are now recommended by multiple international guidelines for nearly all people with HIV age 40 or greater. Numerous other benefits of statins may be even more relevant to people with HIV in Asia. And statins should be prescribed to all people with HIV at least age 40 or older, but probably even less than 40, especially in Asia. And I will turn it over to my counterpart.
Thank you, Dr. Christine. Let's give her a round of applause. And our next speaker is Dr. Wong. Are you there? Can you hear us? Hello, Dr. Wong, can you hear us? Hi.
Okay, there was a little bit of a lag there. And you can hear me, right? And you can see my slides as well?
We can hear you, and they're just about to bring up your slides. You are a giant talking head right now behind us. But now we have you in the proper scale, and your slides are up. So whenever you're ready, Dr. Wong, you can begin.
Okay, thank you very much. And once again, I apologize for not being able to be there to debate in person. But, let's just cut right to the chase. And I think it's really unfair for the first speaker on the proposition to have changed the motion of the debate, as the debate is starting. The debate today was really given to us as a standard of care. Statins should be standard of care for people living with HIV in the Asia Pacific, and not that it should be prescribed for everyone in the Asia Pacific. I think there is a nuance there, but something that I will perhaps dissect a little bit more closely later on. I just want to spend a minute or two dealing with some of the points that Christy brought up. Yes, there was a reduction in MACE. No one is denying that. And I think, in fact, this forms the basis of one of my own substantive points that's going to come up in a few minutes. She brought up the point that Reprieve had global results, people from all over the world who were participants in the study. But I think I'll show you in a really interesting map later on that the Asia Pacific is, IGAD, slightly larger than just South Asia and Thailand, which was the only Southeast Asian site. And the peoples of the Asia Pacific region are perhaps can be considered a little bit more ethnically, genetically, and physiologically diverse than just the representation from the participants in Reprieve. She mentioned that pitavastatin should be given to everyone because pitavastatin was safe. And I think that safety, I should hope so, it's a very low bar to be given everyone a drug for whom we've only just recently found a new use case. And yes, it has many other effects, but the point today is really about whether everyone should be given it or should it be set down as a standard of care, and all of the implications, legal implications, medical implications that come about from making something standard of care. And the last point I just want to briefly talk about, which I will sort of touch upon later as well, is the fact that there's only a slightly increased risk of DM or diabetes mellitus, and perhaps this could be accounted for by the risk factors that make these patients more likely to have DM in the first place. Now, my point to that is that should we really then be giving them a hand in getting diabetes, especially since diabetes is a slightly more of a problem this part of the world than in the global context. Now, the standard of care refers to a benchmark that determines whether we as a professional prescribers or physicians have to patients and whether these obligations have been met. And a failure to do so would constitute negligence, right? Negligence is an important important thing to take note of here. If we don't give statins, can we be considered negligent? Can we be considered to have fallen foul of professional standards, legal standards, and statutory standards? And that is the thing that really the proposition has failed to show today. We are not debating here whether or not statins should be used in people living with HIV who need it. We are saying, in the spirit of the debate, that everyone should be given statins. And I think that Christy really hasn't shown enough evidence that this is something that will benefit people in the Asia Pacific overall. So I'm going to try to prove that on the strength of the primary evidence, that on the application of trial results, that in the risk-benefit analysis and in the acceptability or acceptance of the findings, that we should not yet make statins the standard of care. Now, the study quality for Reprieve, I think, is undeniable and unreproachable, right? The largest clinical trial representing people living with HIV and with a significant number of women, and some representation from the Asia Pacific, mostly in India as well as in Thailand. Now, it's been widely published. I think it has moved towards being incorporated in more and more clinical guidelines. And once again, harkening back to the point that Christy made about international guidelines, all having included pitavastatin, most of the guidelines I think come from either Europe or the West, and I think in terms of Asia Pacific, really incorporation into guidelines remains, I think, something that is yet to be. But the reduction in MACE, most of this reduction happened in those where the risk was the highest, and almost none occurred in people with a low risk. So when you pull the results of everyone together, yes, we get a fantastic result of a reduction in major adverse cardiovascular effects. But when you really drill down to who we are talking about today, those who would not otherwise need it using current recommendations, the benefit is really a little bit less. And so saying that we should give it to everyone, we have to incorporate what the potential risks are. Now, I've sort of touched on the point of applicability. The Asia Pacific is, sort of this map here on the left, and yet the sites that involve the Reprieve participants is really here on the map on the right, which was taken from the Reprieve website. So I think the primary source of evidence, as it were. The proportion of Asians in the trial, yes, greater or more than in other trials that have involved international sites, but really only 15% of all participants. So the applicability in our part of the world, I think the burden of proof hasn't really been shown. The risk of diabetes I've talked about, there's an incidence rate of 3.24 per 100 patient years in those with more than 2 risk factors, as compared to only 0.34 in those with 0 risk factors. Jumping on a statin, where we are not that sure of how great its impact is on giving people diabetes, I think it's irresponsible to make it a standard of care, to make it something that everyone should get. So what should we do instead if it's not standard studies? We need to look at different populations within the Asia Pacific with different cardiovascular disease risks and the effect of other more commonly available statins. Perhaps pitavastatin is not that commonly available in Singapore. I'm not sure about the rest of Asia Pacific. We need to develop better cardiovascular risk predictors. The ones that we commonly use nowadays, with the exception of the ASCVD, those things like Framingham, do not include people living with HIV. It hampers our ability to select those who are the most likely to benefit from such therapies. And so just blanket, carpet bombing everyone with statins isn't really the way forward. We should make talking about statins, lowering lipids and other cardiovascular risk factors a standard of care, not giving people medications. I think making a prescription a standard of care is a lazy, maybe taking the easy way out. And what we should do is to use this trial to inspire conversations with our patients and tell them about how important it is to have tailored interventions for specific clinical situations. Thank you very much.
He indirectly already, accepted what we said, but he little trembled here and there, which we want to fix him in the next few minutes. So, as we all know that, you would have seen these slides again and again, these non-infectious comorbidities on the rise in lower and middle income countries, particularly in Asia. I don't want to show any number of slides on this. I think Wang should spend the next 6 minutes reviewing many of those Asian articles. We all know that inflammation causes this, HIV upregulates, co-infections, particularly TB, causes more inflammation, can cause many of those non-communicable diseases, and over-the-top obesity. When I'm saying obesity, we're using a lot of integrase inhibitor. Yesterday, we had a lot of discussions on this. I personally feel this obesity can also contribute to a lot of cardiovascular disease, particularly by the use of integrase inhibitors, which is very clearly shown in the advanced study in Johannesburg, where in women population, they have seen a huge weight gain, and as compared to the earlier efavirenz-containing therapy, as well as in men. This all not been seen only in Africa, but also in other Asian countries, as well as in India, we started seeing this. And over the top, this is again a meta-analysis of all these published studies of Namisol, Advance, and DEFT. And these studies, recruited in resource-limited setting in sub-Saharan Africa and as well as in Asia, very clearly have shown with the usage of these integrase inhibitors, high risk of developing hypertension and cardiovascular disease. So we need something other than antiretroviral drug to prevent this morbidity. And also these cohort studies of response have shown, the analysis of sub-studies have shown higher dyslipidemia and diabetes. Again, we all attribute to the inflammation caused by HIV despite this suppressed antiretroviral therapy. And beautifully, Christine showed the science on this. But Wang little trembled on this. For me, science is the same in San Francisco, in Chennai, Bangkok, as well as should be in Singapore. If it is a little different, he need to ponder around. This very clearly shows that in this Reprieve study we showed, there is a higher, greater effects had been seen in our Asian population. We recruited a large number of participants from India as well as in Bangkok. It's because we didn't have other NIH reprieve sites in other Asian countries. I personally feel science should be the same if Wang repeats this in Singapore, this trial. And following these scientific evidence, all the research setting guidelines quickly moved to that. WHO is still debating, hopefully we'll come up with some answer. And over the top in resource limited settings, you all know that TB continuously causing issues to our patients. And we have some evidence that it can reduce the risk. And also on treatment, while using on statin, there is an increased better outcome and as well as less liver injury. And again, our region is being, high risk for hepatitis B prevalence. And also there are studies have shown by patients who are on statins, they got a lower risk for liver outcome and as well as there is lower mortality, particularly in MASLD patients, which you also heard some data yesterday, during those presentations. So with all these, we always talk about the availability. Again, Wang was said that, where it has been available. Generic statins are widely available. It's like water in India, I'm sure in all our Asian countries. We have atorvastatin, rovastatin, and pitavastatin. Over the top, our generic manufacturers can combine even this with our tenofovir, lamivudine, and dolutegravir as a fixed dose. You put it in the guideline, if you accept this, we'll give you FTC of all these as one pill, which will be again easy for our patients to do. Then coming to the cost, managing cardiovascular disease is very, very expensive in lower and middle income countries. If someone gets hospitalized with a heart attack in our hospital, it can cost anything from $3,000 to $10,000 per management, or it's not available. You compare about the cost of our antiretroviral therapy, just $70 per year, where the cost of managing. So we need something else to prevent this cardiovascular disease. There are many cost-effectiveness studies. I don't have time to talk about this. The polypill study and statin cost-effectiveness, modeling studies, all have very clearly shown using statin is cost-effective everywhere and should be in resource-limited settings. In conclusion, we all know that despite antiretroviral therapy, HIV persists, and because of there will be inflammation, our patient will continue to develop cardiovascular and other non-communicable diseases. Now, we have evidence using statins, which can prevent non-communicable diseases. And as part of our therapeutics, now we need to optimize care along with antiretroviral therapy a statin. I personally feel statin will prevent NCD pandemic in lower and middle income countries. Hope Wang changes ideas now, and also, his thinking, and he may vote for us. Thank you again for this opportunity.
Thank you, Dr. Kumar. And our final speaker will be Dr. Prin.
Okay. First of all, before I start, I would like to say thank you to the organizing committee who chose me to come onto this stage among the HIV expert, and I'm not an HIV expert. I'm just a cardiologist who's normally my work, I give a lot of talk on how to convince people to use statin, both doctor and patient. And today, the committee asked me to do the opposite side, what I normally do. But that's okay, that's okay. Let's start with this slide. The fantastic reprieve study. As you already heard the first speaker and the third speaker talk about this, the hazard ratio of 0.65 and the relative risk reduction is 35%. But if you look at the graph, in the original scale, not 1,000-time magnifier to see the separation of the graph, what can you see here? It's not quite impressive as you heard before. At 4 years, you see, the graph still look the same. Very minimal differentiation between pitavastatin group and the placebo group. So if someone asks me, which diseases that I would recommend statin for all? At the moment, for primary prevention, there are only 2 diseases that we will give statin to all of the patients. First is diabetes mellitus, and the second is the familial hypercholesterolemia. This data come from the InterHeart study, which is about 55,000 people around the globe. You look at the odds ratio for developing the myocardial infarction, and you can see that diabetes and FH has 3 to 4 times higher than those without this disease. Hypertension has the odds ratio of 2.48, and HIV is around 2.16, or some say it's about 1.5 to 2 times higher risk than people without HIV. So we do not give statin to all of the hypertensive patients. Anyone here has hypertension? Oh no, you are so young. For hypertension, we do the risk calculator. And if your risk go beyond 10%, then statin is recommended. So we do not give statin to all of the hypertension. Why would we give statin to all of the HIV? In all of the major guidelines around the globe, to tackle with the dyslipidemia or to for the primary prevention for cardiovascular disease, people with HIV, we give them 1.5 time multiplier to the conventional risk. So you do the risk score first, and then you multiply the risk by 1.5 to be the final risk that you take. And if the risk go beyond 7.5%, then we give statin to them. And this is my final slide. They give me only 6 minutes, and my English is not that good, but it's okay. This one will, I think, will change all of your mind. Number needed to treat is to tell you how many people you need to treat for pitavastatin for 5 years. Take pitavastatin every day for 5 years. 106 to prevent one event, to prevent one cardiovascular event. I give you also the number needed to harm to get one excess case of diabetes mellitus. In reprieve study, it's 77. So if you treat all of the people living with HIV, you get more diabetes than the prevention of cardiovascular disease. So what I would recommend you is that you choose those who have the risk score more than 5%. And you can see here, the number needed to treat come down to 53. And this is the standard number needed to treat in all of the major guidelines that we are using in cardiology, in dyslipidemia. The number needed to treat for moderate intensity statin for 5 years is about 60. For high intensity statin is about 40. On average, it will be about 50. So if you choose only this and give statin to all of them, I think it's a wiser way to tackle with this epidemic in the people living with HIV. Otherwise, you get a higher NNT, higher number needed to treat, with the same number needed to harm. So my final statement is that statin should not be the standard of care for all of the people living with HIV, but for every people with HIV who carry more than 5% risk, which when you multiply by 1.5, it will be equal to 7.5% that we normally give statin to those with 7.5%. And also with those with compelling indication like diabetes mellitus or FH, or those who have established ASCVD. Thank you very much.
Thank you. And special thanks to all of our speakers for staying within time. And that really gives us the opportunity to have a robust discussion here within the room. So I know it's very difficult to be the first person to stand up to ask a question, but I encourage you to come up to the microphone, because then you get the opportunity to encourage other people to come up behind you and to ask a question. So please, I feel free to come up to the microphone. And thanks to Professor Peter for being one of the first people. We have 2 microphones, front and back microphone. Oh, because there is no microphone in the stand.
Thank you.
Thank you. And please,
Is it on?
yes, please give your name and then direct your question to
I will.
the
Peter
panelists.
Rice from Amsterdam. So thank you for very interesting viewpoints. The one thing I wanted to bring up in the sense of who should we choose or who should we not choose, and which was interesting for me from Reprieve, but also from earlier data, is the difference between men and women. So the efficacy was similar in men and women, but what is intriguing is that women living with HIV seem to be at increased cardiovascular risk, including when they're younger. So my question to everyone is, should our thinking be different for women and men? That's my first question.
Oh, there's a microphone on the table.
You can.
Thanks, Peter. I think here our debate was, we have been debating for, the role of statins to give to everybody, to start with less than 40 and to give it to everybody. Here, when you talk about the risk here, HIV itself is a risk. We are not curing HIV. We are only suppressing the virus. There are enough studies. I know your centers had been participated. There could be inflammation, even a low-level viremia. Will continue to be a risk irrespective of this age group. So now come to the point on, starting treatment, go back. The number of people who develop an opportunistic infections, more than 500, will be a very small percentage. But on the other hand, we are putting millions of people who are asymptomatic on antiretroviral treatment, even to prevent that risk. So coming to your public health programs, it might be very difficult to choose out who will be that. Now, because the woman population in that particular age which you have been talking about, probably another one might have a more risk. We may not know. We may not work upon all the other risk factors behind it. Again, having said this, I think with all the available signs, I may not, that sideline, that one particular population, I may give it to everybody because we have robust scientific data stating that, it prevents, cardiovascular disease and as well as a death.
Yes, I think I would treat them the same. Normally, we in many studies, there are fewer women in the study. And that's the disadvantage of being a woman. But in the recent year, we talk a lot more on the cardiovascular health of the women. What I would like to suggest is that to do the risk score, both men and women, and treat them the same. I mean, you may have to be more caution on the women because they have a smaller body size and may have a higher risk of the myopathy or the muscle symptom from statin. But in the end, if we can lower their LDL down to target, they get the same benefit.
Okay.
I think there.
Yeah, go ahead.
Reprieve did do a better job enrolling women than some prior HIV cardiovascular studies, but it was still about 20%. And we don't have wide representation of the menopausal transition, so I don't know that we can necessarily answer the question of are perimenopausal, premenopausal, postmenopausal women at greater risk. With the way that the study enrolled and the risk categorizations as well, there were not a lot of older women. And I think the big question that comes up is what's the impact of statins over longer than 5 years? And certainly we can't show that in Reprieve. And yes, that graph looked tiny, but that was 48 months of follow-up, not the 20 years or the 30 years that someone's taking a statin, in which that risk may be much different. So having women start statins at a much younger age may totally change the trajectory over time, which is why we should recommend statins in everyone, regardless of their age.
Could I check if Dr. Wong is also with us? So,
Yes, I am.
so
And
Chen,
I think,
Chen-Tong, you are welcome to jump in at any point.
Okay, thank you so much. I think listening to both the question the question from the floor as well as the responses by my fellow speakers, I think it just brings to mind how, especially when we're managing our patients, our cohorts of patients, where we are so used to this concept of managing them for life, where it's an incurable disease that. And the increasing body of evidence to suggest that even for people with well-controlled HIV, that there is this great degree of inflammation, which can have untoward or deleterious effects later on. We are we are very keen, I think, to jump on anything that we think or that we feel or we see in our data gives us some kind of additional benefit, additional survival benefit or prevention of chronic disease or prevention of some other expensive, perhaps debilitating condition, that we jump on things perhaps without taking the time that's necessary, I think, to consider what are the nuances and differences. I think everything that Dr. Kumar, Dr. Christine, and even my co-speaker mentioned suggests to me that there are enough differences amongst and within populations that to suggest that the same dose of the same drug be given to everyone as long as they have HIV sounds to me to be slightly far-fetched. I will deal with the rest of the points in my official closing speech later on. Thank you.
Thank you. And I believe that Dr. Peter had a second question, but we'd encourage more people to come up to the mic.
Maybe that's something for you to take up later in the discussion, and I know it's a topic close to your heart, Annette, and that's perinatally infected children with HIV. And of course, the reprieve doesn't show us that, but such children who've been living with HIV their whole life, who have gone through periods of no treatment or suboptimal treatment, and there are data that that population is at increased cardiovascular risk. And is there any thinking about cardiometabolic health for that particular population? But feel free to take that later.
I think we use the same rule. If they have risk more than 5%, then multiply by 1.5, it will be 7.5, then they are entitled for statin. But for those with a risk lower than that, especially in younger patients, because most of the risks are derived by the age and comorbidity, I think that they can use something like a lifetime risk score, or they can look at the other risk enhancer. At the current time, I think the best one may be the coronary calcium score that might help to identify. You may pick up about 10% of the lower risk patient to already have the coronary artery atherosclerosis, despite having a very low risk.
Thank you. We'll move to the back microphone, please.
Thank you. I have a couple of questions. The first is about what is the actual recommendation? Is it about the pitavastatin or any statins? Because the muscle pain we saw in the presentation, like this pitavastatin is good with the muscles, but there are examples of muscle pain, leg pain specifically with atorvastatin. And we have seen example in our clinic when we prescribe atorvastatin with ART, people experience leg pain and come back to the clinic for withdrawal of the atorvastatin. So that is something which we need to be very careful while designing our recommendations. Second thing about the diabetes, as we saw, the pitavastatin can cause there is slightest of risk for diabetes. At the same time, most of the PLHIV are currently on DTG-based regimes, and DTG is having some kind of hyperglycemia. So what is the scientific evidence about co-administration of DTG and the pitavastatin? The third thing is about the...
Can we stop just at two first? And so I will answer the first one, which is for today's debate, it's just statins in general. So it's not specifically only pitavastatin or only atorvastatin. So that's more general. But if Dr. Christine, you could answer the question about dolutegravir that the doctor asked.
Yeah, and I'll comment first on the muscle aches with atorvastatin, and I think in general the guidelines are you can start any statin, atorvastatin, rosuvastatin, or pitavastatin. If someone develops myalgias, oftentimes they will resolve with change to a different statin. And so I think the question or the emphasis on statin is still there. There just may need to be some switching based on tolerability. And with DTG, I think that there's probably a lot of hyperglycemia and ongoing diabetes risk, and that may indicate that it's even more important to have individuals on a statin, particularly if they're coming in once a year. We may miss new onset diabetes, and at least we can decrease that growing atherosclerotic burden that they're experiencing over time with the weight gain and the diabetes potentially that they may be having with dolutegravir.
And your third question?
Yeah, it's about the common side effect of statins as sore throat. So I don't know if pitavastatin is having that kind of side effect or not, but my worry is specifically related to the operational issue. When we have this statin available for everyone in the larger population, specifically if I talk about the India, and we have only the reliable screening test for TB is 4S screening, and we ask any cough can be TB. So it may increase a huge burden on the CB-NAT testing facility, because everyone with statin, if having sore throat, presenting with cough at the clinic, people might misinterpret it as a TB and then start referring them to the CB-NAT testing facilities. So that is my worry. If that is not the case, then it's fine.
Dr. Kumar, do you want to answer that?
I don't think, the sore throat in statin, is a huge problem. It's been, anecdotal cases already been reported. So, but on the other hand, your question on this pain, leg pain, which has already been shown, but we didn't see that increase in the REPRIEVE trial, and as a result, anyone who discontinued, out of this trial. So I think the beneficial effects are huge, and especially cardiovascular disease and as well as death. So I think, which really, should be highlighted rather than these minor adverse effects.
And a question in the front, please. Okay, go ahead.
Hi, Elliot Reyes, CDC. So thanks for this. This is great. And actually, Kumar, you're mentioning about the WHO guidelines. I do feel like this will be the same kind of dialogue that will happen in the room that you and I have been in many times regarding WHO guidelines and its important consideration. And speaking of that, I do think that they call their guidelines a public health approach, and I do wonder whether some of what we're talking about may or may not be consistent with a public health approach in terms of sort of letting perfection get in the way, letting perfection get in the way of the good. I know REPRIEVE was a very difficult study to do, and the idea of then trying to break down some of these deficiencies in the results that I think, all the speakers have rightly pointed out may be just too difficult to do, and at some point we may have to just say from a public health perspective, this is the right, this is what we want to do. Not that I'm going to tell anyone what my vote is yet. And then I also think, and I thought you were going to go there, Kumar, actually, I do think that the TPT story is an interesting story because we give TPT empirically to a lot of people in a lot of PEPFAR-supported countries, and you certainly can say that there's a lot of reasons why you, in an individual, you might say TPT is just not something you should be giving to that person to prevent TB. Maybe their risk of TB is too low, and maybe their risk of side effects is too high. But at the global level, we've decided that TPT is a reasonable approach to prevent TB disease in people with HIV, and I wonder if we're heading in that direction with this question too. Thanks.
Maybe, do you want to comment?
Can I comment on that? I think that's a great point. And the first my opposing presenters mentioned that there were all these legal implications of calling something standard of care, but I think it's really just kind of the semantics of it, and providing that strength of a recommendation of something of standard of care certainly still gives a patient to opt out and a provider to opt out of that. Just needs to be documented, the chart, we do it all the time. I think it just emphasizes the importance of it to funders, to insurance companies, and to patients who sit there and kind of, well, should I or shouldn't I? If it's standard of care and it's recommended, I think it really emphasizes to the patient how important that statin is when they're kind of on the fence.
Could I ask Dr. Chensong, Dr. Wang, this point about a public health approach, are we potentially in a better situation for us to just give it to everyone because it's easier in a public health approach like TPT? Do you have a counter to that, given your role with the Ministry of Health?
Well, I think if we're talking about a public health approach, then with regards to statins in this setting, we really are talking about perhaps healthcare financing, right? The health of the health of the healthcare system. I think the difference between tuberculosis prevention, for example, or other kinds of communicable disease-based public health interventions is that there is the risk not only to the individual but to communities. And I think the parallel is, I mean, there are similarities, but I would hesitate to say that they are exactly parallel or translatable to each other. And I think that while Christy's point about the standard of care being a semantic or legal term is yes, it is got to do a little bit with what the definitions of things are. But I think for the vast majority of patients, and perhaps for the vast majority of prescribers, having something down on guidelines, having something down as perhaps statutory requirement, having something down where people could be taken to task or taken to court for not prescribing, even if there were good reasons not to do so, raises a can of worms, and that's what happens when we have a standard of care for something where, yes, the results were very good in this one very impressive trial, but which is one trial, yes, based on a mountain of evidence, but the specificity of the topic at hand, which is in the Asia Pacific and for everyone, I think hasn't been proven by the proposition. Thank you.
Thank you.
Sorry.
Elliot, do you keep
Yeah,
going?
just one other question, just sticking with the theme of the public health approaches. Does anyone know if there, will also have to be, we're talking about risk factors, so we're talking about risk stratification. And does anyone know if in a public health approach, these risk scoring, such as ASCVD or others, which I've heard there's some question of, women, whether they're right for women and that sort of thing. So all of this, has that been applied in a public health approach? Has that been studied in terms of can it be applied with quality in a public health approach? And whether or not that also, comes into play in deciding whether this is the right standard or not. Thanks.
Yeah, in fact, we don't have the right answer now. We're just working on a cost-effective analysis with the CPAC group. So we will come up with some sort of an answer, what you have been asking for. At this time, now we have the science data, and so just setting guidelines have been changed based on the science from RIPRIV. And we all know that we have got a huge risk factors of NCDs, particularly cardiovascular disease, despite suppressive antiretroviral therapy. I think this is time that how we can involve all those various risk scores in our part of these, guideline. How, as rightly you said about, prevention for TB, despite in places where they didn't have risk, and as well as with the higher CD4.
And I know that there's some CDC representation on the Reprieve publication calls. I don't remember who that.
It's not me.
I was going to say, I don't think there was somebody on, and I know they were talking about public health approaches, but I'm not sure where the analysis is at. Okay. But there is something in the works.
Okay, so I just would like to, to support the CON team in terms of, so just concerning about the DTG related to weight gain and increase the risk of diabetes. And also for the Asian population, they tend to have a higher visceral fat, and it's increased the risk of diabetes, especially from South Asia. So, and do you have any comment on that? One question, another question. So why don't we talk about stopping or quit smoking? Because smoking is also related to cardiovascular disease, related to inflammation, and also increase so many cancer. So compared to statin, and you stop smoking, so the ASCVD risk will be significantly reducing, and also reduce the cost of statin and long-term side effect of statin. Yeah, I think the statin should not be prescribed for all, but maybe specific for some higher risk. So any comment?
Thank you very much. If they take medication for HIV and then they get more obese or diabetes, then you should give them statin. That's a common thing, I think. Other from statin, actually, if I have more time, I can give you some idea about the dyslipidemia treatment at the time of the present time. We have several evidence that many dyslipidemic treatment, not only statin, but also from the ACL inhibitor, NPC1L1 inhibitor, or PCSK9 inhibitor can lower the risk of MACE as well. And that maybe is my request or my asking of you if you can do the bempedoic acid is very interesting in terms of they have no muscle side effect in the same pathway of the statin, and that may be the way out for the people living with HIV, and also with the ezetimibe. So what I want to say is that in the end, if you can lower the LDL down, you get benefit, not only the pitavastatin.
And I'll argue that diabetes is a continuum, and if someone's gaining weight and they're insulin resistant and they have all these metabolic risk factors after they started dolutegravir or other integrase inhibitors, there's not a point in which all of a sudden their hemoglobin A1C becomes 6.5% and their LDL or their plaque increases drastically. So why not put them on the prevention therapy early so that they're not developing that plaque and not further increasing their ASCVD risk? This is a population at risk for metabolic syndrome. We shouldn't wait until the disease is present. We should give them a prevention medicine to prevent them from developing plaque and later developing cardiovascular event. So don't treat the high-risk patient that already has built up plaque and has this high risk for a heart attack. Prevent the plaque from building up in the first place, and that's going to prevent peripheral artery disease, stroke, many other factors that beyond just that question. And then the question about smoking, I think very important point. Wasn't what we were told to debate, so we didn't talk about it, but I think it's also definitely worth mentioning is people should absolutely quit smoking.
Kumar, do you want to add anything?
Yeah, just a word about the smoking. WHO very recently released a document about quit smoking, if not even involving a pharmacotherapy using varenicline. Now, there are clinical trials, our groups and others been involved now. So there will be some, outcome will come out of that, but I won't, stop statins for the smoking. That's entirely for a different reason where there are interventions underway. Now, coming to this question on statins, only on certain population don't need. Now, I think for the audience, you need to know that REPRIEVE trial, we recruited patients who had normal lipid profile. They all had a normal LDL. People who had an abnormal LDL, they were excluded of the trial. So that means we didn't give this pitavastatin to lower the LDL. They all had a normal LDL through, at the time of recruitment. But the science behind that is, which shown in Christine, one of the slides is, this statin expresses what is called the PCOLS protein, and because of that, there is a reduction in the NCP, so atheroscleromatous plaques. So that means there is a huge prevention effect had happened using this statin, if you look into the science. But these cardiologists, they use statin for a different reason. Someone who has got an abnormal lipid profile, they use it to lower. Here, we studied that on a normal LDL, where to show a different reason to prevent that. So I think, with that science, I think holding on certain population, is not the right thing. You should give that benefit to everybody, to have the prevention effect.
So I'm going to ask Dr. Wang to comment a little bit, but this is a last chance in case anybody has any questions. Please feel free to come up to the microphone. So Dr. Wang, Dr. Anjali mentioned, why aren't we just asking people to quit smoking? And this is related to a slide, one of your last slides. I don't know if you wanted to comment on that.
No, thanks, Annette, and thanks, Dr. Anjali, for coming to our rescue. I think that the point that's important to make here is that it is exactly these questions that need to be asked. That it becomes very tempting to pin all of our our hopes, as it were, in terms of preventing cardiovascular disease or major adverse cardiovascular events on a single drug, and oftentimes I think what then happens is the task of having to actually manage other modifiable risk factors becomes, oftentimes I think due to a reality of the amount of time that we have in our clinics, the number of patients that we have to see, becomes secondary. So all of the other things that may have a huge impact on the development of major adverse cardiovascular disease falls by the wayside because we now have something that's easy for the physician to do, which is have a prescription, and for the patient to do, which is pop a pill. I mean, the number of times I've heard my patients say that they don't want to reduce the dose of their statins, even though their lipids are great, because it means they don't have to avoid bacon. I think is really an indication of the fact that we often fall to our, to some of these I hesitate to say crutches, but essentially when we put something there and give it the status of a panacea, we run the risk of blindsiding ourselves. Thank you.
Thank you, and thank you for this robust discussion. We are now going to move into the rebuttals. So the order is opposite, so Dr. Wang will go first, followed by Dr. Christine. So Chen Sang, your 2-minute rebuttal, please.
Okay, so thank you very much again and for listening to the side of the opposition. I was asked before this debate, why does Dr. Annette always put me on the opposing side, which is usually the more difficult side? And I don't know, I think Dr. Annette has something in has it in for me. But thank you very much for listening to the arguments. I think the points that I've made in concluding the opposition's case still stand. We have a great trial. We have a trial that has had a large number of participants, but for which the representation for the Asia Pacific, which is the debate that we're having today, remains, I think, a little bit inadequate. We have a drug that is safe, but which does have, as with all medications, important side effects, and some of these side effects may actually potentiate the cardiovascular risk that some of our patients that we want to give this drug to. We have a drug that we have a disease condition that is not yet fully well understood in terms of the inflammasome and how people living with HIV are at increased risk of cardiovascular disease. But we have some promising data, and we have the risk. We run the risk of adding this as a sine qua non for all the treatment for all our patients living with HIV. And I think all of these things increase the risk of something that's unpredictable from happening, and until we have better data and better systems, I think, to predict the actual cardiovascular risk factors for all of our patients, whether they are the adolescents who have been infected perinatally, all the way to our elderly patients who are the most likely to have advanced cardiovascular effects, saying that all people living with HIV should be on statins is, I think, not yet time and maybe irresponsible. Thank you.
Thank you, Dr. Wang. Applause for Dr. Wang. Thank you. And next, Dr. Christine.
Great points. I think this has been a really nice discussion. I just want to make a couple other points. First, there's not going to be another Reprieve. Reprieve was huge. Reprieve took many years and so much money and effort. So I think we have to use the data that's at hand to make the best decisions that we can. And no, there weren't people less than 40 enrolled. There weren't certain countries enrolled. But based on what we have, we see a great reduction in the Asian population or the Asian sites that were enrolled. And I think we have to acknowledge that and address that risk. I think another point is that atherosclerosis, diabetes are lifelong diseases, things that start early in life. And the earlier that we can intervene, the more chance that we can actually prevent disease, not just treat disease. So thinking in the mind of prevention, what can we do to help these populations? And then I think that the ongoing risk of diabetes with integrase inhibitors is incredibly important, and the more that we can do to prevent the cardiovascular morbidity and mortality associated with that, which we think that statins will offer that, I think is incredibly important. I'm a huge proponent of exercise and behavioral studies. That's what most of my research is. I'm not arguing that we should not continue to promote that, but in practice, it's a lot easier for patients and providers to at least start with a drug that we know that works, and then we can continue to work on lifestyle modification.
Thank you, Dr. Christine. And Dr. Prin.
Again, as I tell you before, the Reprieve study is a landmark study in people living with HIV. What Reprieve tell me is that the statin theory is right. 35% reduction in LDL cause the risk reduction in the same line with the CTT meta-analysis, which is all of the statin study. You get the LDL low in a specific number, you get the event rate low in the specific number. It's perfectly matched with other statin. But what I would like to say is that when the event rate is very low, you get the big result you see, but the absolute number of the event that you can prevent will be high. in reprise study, the NNT is 106. And I do a quick calculation. In the Asian population, the number needed to treat will go up to 232. So it's not we are using in the current medication or current scheme that we would like to treat the fewer patients for a long time to prevent one event. So my finishing point will be the same as that you must select those with a higher risk. Not that high risk. 5% is very easy to find. Maybe not 100% of HIV, but 50% of HIV, and you will not miss it. The problem is not giving or not giving. The problem is that when people who should take statin, we don't give statin to them, or they deny statin and we do not encourage them or convince them to take statin when they should get statin. And I think 50% of the people living with HIV is enough for you to have a hard work to convince them all to take statin. Thank you very much.
And Dr. Kumar.
I think now my next two sentences should change your balance a little more with whatever you're thinking. Now we have enough evidence that the quality of life for people living with HIV while on antiretroviral therapy with suppressed viral load and good CD4 is almost the same like people who do not have HIV. There are publications there from the US and developing countries, under preparation. Again, having said this, now these CVDs, I personally feel, will be some sort of a stumbling block. I think when we have an evidence like a reprieve, where statins are available, we should use it at the right time. We should be preserved. By the time we'll build up a huge pandemic of NCDs in our resource-limited settings, despite providing good quality of life with antiretroviral therapy. And one other thing, my friend Prin, the famous cardiologist from here, argued that so many numbers are needed to treat this. He wants only diseased patient, to do stenting. But we are interested in a public health setting how we can prevent people from going to him. I think we are looking at the holistic way. I think the reprieve data very clearly shows that statin should be recommended. Should be recommended all. Right now, recommendation at less than 40, more than 40 years. But on the other hand, if we look into the people with less than 40, also can have other risk factors like diabetes, obesity, hypertension, so on and so forth. If you put all together, only you leave a very small percentage of the people out. So that means in a public health setting, it might be very difficult to choose out this population. With all these in background, I recommend statin at this time without any delay for everybody to prevent NCDs. Thank you again for this opportunity.
Thank you, Dr. Kumar. Okay, we are now at the point of being able to do the second vote. And so remember that you can capture the QR code on the back of your name tag on workshop number 1. And we're going to ask you to vote again about the proposition. And I also recognize, Mr. Moderator, Dr. Nguyen, that will be done a little bit earlier than expected. So if you have any announcements for us okay. So the second vote on the proposition, if you believe that yes, statins should be standard of care for people living with HIV, type O, in the Asia Pacific, then please vote number 1 or A. If you believe no, statins should not be standard of care for people living with HIV in the Asia Pacific, please vote B or number 2. So you will have 15 seconds after we release the vote to make your decision, and hopefully our esteemed panelists and speakers have persuaded you in one direction or another. Okay, now we're going to start. 15 seconds on the clock. Please vote. Three, 2, and 1. Okay, so what you can see is in the first vote, you can see that 64% believe that yes, statin should be standard of care. And in the second vote, that dropped down to 42%, whereas those who believe that it should not went up to 57%. And I think that even I can do this simple math, that in fact the con side of Dr. Wang and Dr. Prin have won the debate today. Applause to them. But I will say that if we look at this first vote, I think that this really shows you that based on the data that we have seen, there is a strong communications message related to what Dr. Christine and Dr. Kumar shared. And the second vote, I think, reflects that we are not certain. There are still a lot of questions. And so it is possible, in accordance with what Dr. Elliott and Dr. Kumar said, that in the near future, WHO, your own infectious disease societies or cardiologist societies will be making a decision about what is the most appropriate public health approach for your context. And perhaps that will mean that we will see actually a guideline saying that it should be strongly considered for all people living with HIV. If that happens, I hope that what you have heard today will give you some insights and help you to make a decision as to what is best for the patient in your clinic in front of you who you are counseling about whether or not to start a statin. So thank you again to all of our speakers. One more final round of applause. Thank you so much.